Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video is missed by anybody.
Okay. So now, since we're on record, I welcome one and all once again in the class. And tonight is going to be a very interesting class because it's going to be a lot of surgical dissection in my mind and yours too. I'd like to present it in an easier way for everybody to understand, and also what is expected of you in the examination. You do not have to remember, the entire surgery complication list. So list is unending. The pre-op, the post-op, the difficult technicality of the surgery. No. You just have to remember the basic crux of what exactly you're doing it and in which situation would you be doing it. That is expected of you. We're not expecting anything more out of you people. So there are many operations we're going to discuss today from prolapse. Like I said, it's going to include every kind of prolapse, the nulliparous prolapse, the vault prolapse, the uterine conservation surgeries, the sling operation, so on and so forth. And of course, the preventive surgeries so that the prolapse doesn't occur in the first place. So now let me begin with where we left in the last class. So like I said to you before, we were talking about the site-specific repair. When I was taking the quantification system, I was very specific to ask you what exactly is the why do we jump onto the quantification? Our life was going pretty well with Shaw's classification and Baden-Walker classification. We're fine, with understanding whether it's 1 degree, 2nd degree, 2 degree, 3 degree prolapse, right? POPQ also says the same thing, but why is it more important is because sometimes in certain patients, it could only be a cystocele, a large cystocele. In certain patients, it could be just a uterocervical elongation. In certain patients, it could be just an enterocele or just a rectocele. So for those patients, you might not require an entire vaginal hysterectomy along with pelvic floor repair, right? Now, this is one of the favorite questions of examiners. Is it a must for you to do vaginal hysterectomy along with pelvic floor repair in every case, or in every case of prolapse, do you have to do vaginal hysterectomy? Answer is yes or no, and why? Come on. In your chat boxes, everybody, I want to hear this from you. Whether you want to do a vaginal hysterectomy every time you correct a prolapse, if the patient, of course, has completed the family. Let's say there is a 2+ cystocele. There is a 2+ rectocele as well. And let's say there is a 2+, 3+. Okay, fine. Let me make you understand from your point of view. Let's say as far as your POPQ grid is concerned, it is -1 to 0 of your AA point, and your BA point, let's say, has come to maybe -1. And your C point is, let's say, at point, it's still inside, so it's, let's say, at point -2. And D again at the same level. And BP is, let's say, at -2. And AP is at point 0. Now, all this entire prolapse is still inside, right? But it's pretty lax vagina, as you can see. Would you want to do a vaginal hysterectomy as well, or would you just, maybe repair the cystocele along with rectocele, or you will still want to carry on with vaginal? Is it a must for you to do vaginal hysterectomy, or you just do maybe a strengthening of the sacrocolpopexy, something like that, and just do away with it? Why do you want or not want vaginal hysterectomy in every case? Is it a must? Why do you convince the patient for a vaginal hysterectomy? So, since I took a really long time to make you understand the question and still I have no answer, that means maybe you people are confused. Let me tell you guys that until and unless there is an indication for a hysterectomy, there is no need for a vaginal hysterectomy. Correct? So until and unless the patient is, let's say, having a fibroid uterus, which of course is amenable to be managed vaginally, or she's having irregular vaginal, bleeding per vagina, or she's having a polyp, or she's having multiple fibroids or adenomyosis, there is no need actually to remove the, uterus every time you have a prolapse. And could be a prolapse in which there is maybe a stage 2 prolapse or a stage 3 prolapse. Let's say stage 2 prolapse. Okay, it's just peeping out, but it's totally lax. Would you want to go ahead with a vaginal hysterectomy if the family is complete? You can go, there are multiple options, I'll tell you today. But the answer is, for this question, there is no need until and unless there is an indication for a hysterectomy. There are multiple options that you can give to the female. But if she's completed the family, she's all right with, She always fears that fine, this thing is fine, this is taking care of my just the prolapse problem. But what if tomorrow I have maybe postmenopausal bleeding? Then what? In that case, I'll have to get my uterus removed. So might as well just go ahead and remove the uterus. My family is already complete. I'm not getting anything out of it. So I would want to go for it. But there is actually no indication of vaginal hysterectomy every time there is a prolapse. That is the answer. Still you have any query, please feel free to ask me after the class. Anyways, so this was the idea about talking so much in detail about site-specific repair is because once you see the grid that is made in POPQ, you understand that the problem lies exactly where. Is it lying at the level of cystocele? Is it lying at the level of urethrocoele? Is it lying at the level of apex? Is it lying at the level of rectocele or enterocele? So once and for all, you get just by seeing the grid once that okay, this patient is having this particular problem. So you design your answer, or you design your management accordingly. So this we've already studied in the previous class. I was telling you the anterior vaginal wall support system and that of posterior vaginal wall. So the main support to the anterior vaginal wall is basically the pubocervical septum, correct? This one, okay, which is attached superiorly to the pericervical ring and the cardinal ligaments, correct? Again, and also to the ATFP, the arcus tendinous fascia pelvis. Laterally, of course, it attaches laterally to this and to the pubic tubercle on each side inferiorly. Okay, so superiorly it is attaching itself to the pericervical ring and the cardinal ligaments, and laterally it is attaching itself to the ATFP, and of course inferiorly it is going and attaching itself to pubic. It is a very, very tough support system, right? So it's the pubocervical septum. The common defects, they lead to the central defect, right? Then they lead to the both side defects, the paravaginal defects. So you have many defects like this. And then you have both sides detachment of the pubocervical septum, or you have the transverse apical defect. I'll tell you more about it as we go ahead. So you have either an apical defect, you have paravaginal, see, you have a central defect like this. And then you have paravaginal like this, paravaginal defects on each side. And you have a transverse apical defect, not exactly at the apex, but slightly before that. But it's a transverse, something like that. So see, based on this system, the meshes and everything came in between. That why you're supporting only, just in the midline. You support the entire structure because it's, it's lagging properly. But you know what, guys? Now meshes are literally obsolete. We do not use them because there are a lot of issues with meshes. Their erosion, their continuous discharges, so much so that they cause so much erosion around it that, fistulas have also been formed. So meshes are slowly coming down. We'll take up that topic as well towards the end. So what was the success of such a long time we've been successful by doing just the plain simple surgeries? Patients usually do not come back with a lot of problems. The reason is that you're plicating the entire structure. You're kind of bringing it in the midline. So the entire defect is as it is getting all right. It's not lax anymore. You're pulling it in the midline. You're also cutting the redundant folds and then you're kind of bringing it in the midline. So whatever defect was there, it is getting straightened up as it is. Are you getting this point? It's no more lax. So be it, in the midline or be it vaginally, the defect is getting the support in the midline. But still, after that also, if you feel that it's getting lax, you'll have to take some buttressing suture in that particular area as well. That was the idea of bringing this matter called as the site-specific repair. Now, what exactly happens in the posterior wall? The posterior vaginal wall is supported by the rectovaginal septum, like this one was supported by the pubocervical septum. This is by the rectovaginal septum, and this is attached superior to the pericervical ring, to the uterosacrals, laterally to the fascia, and inferior to the perineal body. This you should know. Common sites of injury to the septum, having the transverse apical defect, or the midline vaginal defects, or the lateral due to the injury. So this could be, again, the same three defects, the midline effect, the paramidline effect, and the transverse apical problem. So now I'll tell you how to get to understand these defects. Which one are you? So you know this from a really long time. You just take the ring forceps, all right? So you support the posterior vaginal wall with the help of speculum, and now you're inspecting the anterior vaginal wall. You take the ring forceps and you keep it in between. You just support it. Ask the patient to strain, and you see a paravaginal sagging. So you see that this is paravaginal defect coming down. If you open the two spokes of the ring forceps and support the two sulci, and you see that this is dropping in between, you see it's a midline defect. It is what is told over here. The midline defect is suspected if there is a midline bulge noted. Okay, when the lateral sulci and the apex of vagina, they are supported with the ring forceps. Correct? Which I just told you. And the paravaginal defects, they appear as blunting or a descent in the lateral sulcus on either side when the patient is straining. Correct? So that's how you understand the anterior defect. All right. The transverse defect, they are seen as distinct bulging out of the anterior fornix, which is smooth without rugosities. See, when there are rugosities on the vaginal wall, right? But when you go to the apex, that is the vaginal vault literally, then you see a sagging at that point. Towards the end, you see, when you start withdrawing and there comes a bulge. Suddenly, after the moment you withdraw from the apex, there's a bulge. You understand that this happens to be the apical, the transverse apical bulging. Correct? Again, not straining too much over here, guys. Why? Because the actual part of prolapse is not this. Despite the fact, having understood the the site-specific defect, there is not much that we can do apart from the meshes. And meshes, they are getting obsolete slowly. So we are not going to discuss this properly and too much in length. So therefore, coming down to this beautiful slide, which I had to think a lot before making it for you people, to make it simple and easy for you. Management of prolapse is actually basically this. The one which is asked in examination is not site-specific repair of paravaginal defects. It's mostly in the books. What is asked in your exam, what is expected out of you, and nobody is going to pass you if you do not know this much, is what I've included.